This lecture is going to be a rapid fire of the high-yield diseases that we talk about in greater detail in the pediatric lectures. This video is intended to be used only for shelf studying for your surgical shelf. We're not going to go into great detail, we're not going to explain, so if you're studying for your step, skip this video, watch Peds. If you are studying for your surgery shelf only, watch this video, take the highlights away. These diseases in this video are going to be the ones that are present immediately upon birth. Generally, you see them and you're like, wow, there's the disease, it's there. You don't have to wait. And it's usually going to be obvious when they have it, and if it's not immediately apparent, then it's apparent within the first day of life because they have the pathology from birth. We're just going to go through the different diseases one at a time. There's really no link here other than when you find them. The first is tracheoesophageal fistula. And this gets a little bit more complicated because you have some combination of atresia and fistula. And depending what's connected to what and what has the blind pouch, whether it's the proximal trachea, the distal tracheoesophagus to tracheoesophagus to trachea below, there's different variants. All I want you to know for surgical shelf is fistulas and atresia. The atresia means a blind pouch, and the one that matters is the one that comes from the mouth. It's totally blinded and does not connect to the stomach. There may be, this is the trachea, there may be a fistula between the trachea and the esophagus, proximal or distally, as it goes to the lungs. The idea is that there's multiple variants, there's atresias, and there are fistulas. See why this becomes important in just a second. The patient, the baby, is going to present with gurgling. Something that says there is a connection between the food hole and the air hole. There's going to be air breathed through the esophagus and food swallowed into the trachea. So there's going to be gurgling, coughing, or bubbling. Those are the words you're looking for in a newborn. The diagnosis is made by coiling a tube. You pass an NG tube, you think you're in the right place, you get an x-ray, and what you see is coiling. The treatment for this, of course, is surgical repair. But before you do that, you have to consider the Vactural syndrome. Hang on to that. Part of the Vactural syndrome is imperforate anus. And the imperforate anus is exactly what it sounds like. This is why you do not take the first temperature rectally. If they don't have an anal opening, it's not connected to the rest of the bowel, if you insert a thermometer into that, what you think is supposed to be an opening, you actually just stab into the peritoneum. That's a knife wound. Imperforate anus comes in two varieties. The mild form, which is going to be where most of the GI tract is almost up to the imperforate segment, and severe, where the bowel is very distant to the anal opening. The patient is going to present without an asshole. There's no anus. And you make that diagnosis by looking at it. But you do need an x-ray to determine the severity. And that x-ray is not just any x-ray, not just a regular babygram, but instead it's going to be a cross-table x-ray. And that cross-table x-ray is going to tell you how bad it is. The treatment is surgical. But if it's mild, that is, they're very close together, you just fix it now. If it's severe, you want baby to grow a little bit so you've got more bowel to play with so that you can more easily connect it and have success. Since they're going to be incontinent of stool anyway, you do a colostomy and reverse it before toilet training. Here's the thing. TE fistula and imperforate anus are all part of Vactural, and we talk more about Vactural in the Peds lectures. The takeaway is that if you find any one of the Vactural, and it's in your notes, you don't just go to surgery to repair it. You first investigate for the other features of Vactural. Most importantly, do they have a tracheoesophageal fistula or an atretic portion? That is, can you intubate them? And you must also do an echocardiogram to find out if there are cardiac defects. Can they tolerate the surgery, or do they need another procedure first before you fix the imperforate anus. That's how the test is going to get you. If you see TE fistula or imperforate anus, look out for diagnostic steps for VACTERL before you proceed to surgery. The next three diseases are very commonly tested against each other, not because they are confusing, not because if you look at them you're not going to be sure what they are, but because the vignette sounds very similar. These diseases, gastroschisis, omphalocele, and exstrophy of the bladder, all have something to do with something coming out of the belly. And so what we're going to do is use this cartoon to illustrate the disease. This is baby. And the dashed line represents midline. And one of the things I do to remember which one is which, gastroschisis sounds angry and ugly, and it's the uglier version. Omphalocele sounds nice and happy, and that's the better one. And exstrophy of the bladder is the third one that has nothing to do with bowel, so just leave that one alone on its side. Gastroschisis, gnarly, angry sounding. It is going to be to the right of midline, and it is going to be bowel all over the place. Looks angry, sounds angry. It is bowel without a membrane. Omphalocele sounds kind of happy, right? So it's a little contained sac. Whoop. Still bowel, but it's contained nicely in a sac, and it is midline. Exstrophy of the bladder is the thing coming out of the abdomen in the midline. And so you can see by pictographic representation, it'd be easy to just learn about omphalocele and exstrophy of the bladder and get them confused. Gastroschisis and omphalocele are both diseases of the bowel. Gastroschisis has no membrane, so there's going to be just loops of bowel all over the place. And it is found to the right of midline. Omphalocele has a membrane, and within the sac is bowel, but it's neatly contained, and it will be exactly at midline. The diagnosis is going to be made clinically. You literally just see it as baby comes out. And the treatment is with a silo. The idea here is that bowel is supposed to come out of the abdomen, rotate, and go back in embryology. In this case, it never came back in. But when you create a sterile silo, you essentially just turn a dial, and the bowel goes back in over time, and then you suture it shut. Doesn't matter which one it is, the silo is the treatment. So you can either be asked what's the diagnosis or how to manage. Exstrophy of the bladder, not surprisingly, is the bladder. And so there's not a membrane per se because it's the bladder and it's midline. But what you're going to be using in the vignette to tip you off that this is exstrophy of the bladder and has nothing to do with the bowel is they'll tell you no bowel. But if they don't, look for wet, shining, or red. Those are the key words in an infant question with something in the midline, because wet, shining with urine, and red is the color of the bladder as opposed to the bowel. Exstrophy of the bladder is also a clinical diagnosis, but this is simply surgically repaired. The next disease is congenital diaphragmatic hernia. This happens either in the back, the posterior, which is called Bochdalek, or the anterolateral, or Gagny. There's a hole in the diaphragm, and bowel is allowed to come up into the chest. So what you're going to see in the patient is a scaphoid abdomen. Babies' bellies are usually protuberant, full of bowel. If instead all the bowel is in the chest, the abdomen is going to be scaphoid because there's nothing there. And if you listen to lung sounds, you're going to hear bowel sounds in the chest. This diagnosis is confirmed by getting an X-ray, and you see bowel in the chest. Now, this is actually not that hard to repair, so obviously you're going to repair the hole and pull the bowel down. But why this becomes a board favorite is because if you have bowel up in the chest while the lung is developing, the lung stays collapsed and nothing opens or matures appropriately. So effectively, you have a hypoplastic lung that is effectively a preemie lung. So the hypoplastic lung can cause problems for baby in the sense that they may need to be intubated and given surfactant in order to expand the lung that is hypoplastic and crushed by the bowel. So recognize the diagnosis, but know that hypoplastic lung is the thing you're going to have to manage. We are going to finish with biliary emesis. And this topic has an entire lecture dedicated to itself in pediatrics. Here are the highlights. When you have biliary emesis, you're presuming there is an obstruction distal to where the gallbladder biliary tree connects to the duodenum. Because it's a problem with the bowel, you're going to get an X-ray. And what you're going to see on that X-ray is a double bubble. It is what is in addition to the double bubble that helps you separate which disease it is. There are 3, which turns into 4. You'll see what I mean in just a minute. If you have a double bubble, and then you also have normal gas distally, it means that the bowel was open so that when baby came out, air was able to get through the whole thing, and now there's an obstruction distal to the biliary tree. This is malrotation. Malrotation is going to be a life-threatening disease because it is cutting off the vascular supply to that segment that malrotated. What you're going to do is do first a contrast enema, which can be both diagnostic and therapeutic. If it doesn't work, you can use an upper GI series. An upper GI series often fixes the problem. But if you don't fix the problem with either of these diagnostic steps, then you need to go in there and do surgery, untwist the bowel before the vascular supply kills off that segment. If instead you have a double bubble and multiple air fluid levels, this is going to be intestinal atresia. Intestinal atresia is caused by in utero infarcts. The infarctic segments now do not recannulate, and therefore multiple areas along the way are obstructed. The way this happens is mom uses cocaine. It can happen other ways, of course, but this is what you really want to investigate to make sure that she doesn't do it with the next kid. The only answer for this child right now is to remove the intestines that have been atretic. If you remove too much, you end up with short gut syndrome. If you have a double bubble sign alone, that is double bubble and then no gas, it is either going to be, this is how we turn 3 into 4, duodenal atresia or annular pancreas. Duodenal atresia and annular pancreas are effectively the same disease because they have the same presentation, even though they are 2 very different genetic diseases. The answer for both is simply surgery. Okay, what we did was rapid fire. These are the diseases that are present on the first day of birth. You usually just notice them. Remember that tracheoesophageal fistula uses the coiling of the NG tube, and imperforate anus uses the cross-table X-ray to make the diagnosis and how bad it is. If you find either, do a echocardiogram to make sure they don't have a problem with their heart as well, Vacral syndrome. Gastroschisis, angry sounding, angry looking. Bowel, no membrane, right of midline. Omphalocele, happy sounding. Membrane, midline, bowel. Exstrophy of the bladder, something in the midline that's red, shiny, and wet. Silos for gastroschisis and omphalocele, surgical repair for the bladder. Congenital diaphragmatic hernia, If you diagnose it, scaphoid abdomen, bowel sounds in the chest, remember there's the hypoplastic lung that may require intubation and surfactant. When it comes to biliary emesis, use the X-ray with the double bubble and the other gas pattern to figure out which one it is to determine what their next step is going to be. That's Peds, hours to days. Become a better doctor. Subscribe now to get access to our premium content.